47 pages, color-coded graphs, a leather-bound folder. That was the executive medical a client handed me last year. Every marker in the green. His consultant said he was in excellent health. 6 months later, I was explaining to him that he had early-stage cardiovascular disease that had been building for over a decade. Not one of those 47 pages would have saved his life. If you want this kind of evidence-based insight every week, subscribe to this channel. New deep dives every Tuesday. And if you want to know where you actually stand right now, not where a standard panel says you stand, take the free Executive Longevity Scorecard. 8 minutes personalized report, link in the description. Now let me explain why the system most of you are relying on is fundamentally broken. Here is the core problem with the annual executive medical. It was designed to detect disease that has already arrived. Not disease that is developing, not dysfunction that is building, disease that is already clinically measurable. That is not prevention, that is damage assessment. Think about your office building. You have a fire alarm. It tells you when the building is already burning. Useful, certainly. But you also have a smoke detector. That tells you something is wrong while there is still time to act. Before the flames, before the damage, before anyone gets hurt. Your annual health check is a fire alarm. What you need is a smoke detector, and the difference between those two approaches is not marginal. It is the difference between catching a problem at 50 that your GP would not have flagged until 62. That is 12 years of silent progression, 12 years where intervention would have been simple, inexpensive, and almost certainly effective. By the time the fire alarm goes off, intervention is complicated, expensive, and the damage may be irreversible. I have practiced medicine for over 3 decades. I left mainstream practice specifically because I could not continue watching intelligent, high-performing people walk out of screenings feeling reassured when I knew, from the literature, from clinical experience, from the patients I was seeing downstream, that the reassurance was false. Let me show you where this breaks down at the most fundamental level. When your GP tells you a blood marker is normal, here is what that word actually means. Your result falls within a reference range that was calculated from the average results of the general population. And that population includes people who are overweight, metabolically compromised, chronically stressed, and sleeping 5 hours a night. The reference range tells you that you are not an outlier compared to the average. It does not tell you that you are healthy. Let me give you a specific example: fasting glucose. The standard NHS reference range considers anything up to 5.5 millimoles per litre as normal. But research published in the BMJ shows that cardiovascular risk begins rising meaningfully above 4.7. So you can have a fasting glucose of 5.3, green light, normal, no concerns, while your cardiovascular risk is already climbing. And it will keep climbing silently for a decade before it shows up on a standard screening. Now imagine running your business this way. You benchmark your company against the average performance of every company in your sector, including the ones that are failing, the ones hemorrhaging cash, the ones about to go under. And when your numbers come back average, you call it success. You would never do that. Your business would have failed years ago. Yet that is exactly how most of you are monitoring the one asset that determines whether you are alive to run the business. Now let me show you 3 specific blind spots, 3 markers that I test on every single client who walks through my door and that I almost never see on an annual executive medical. Marker number 1, ApoB, apolipoprotein. B, your annual medical tests total cholesterol and LDL. Fine. But the single best predictor of whether you will develop atherosclerotic cardiovascular disease is not LDL cholesterol. It is ApoB, the number of atherogenic lipoprotein particles in your blood. Here is a way to think about it. LDL tells you how much cholesterol is being carried. ApoB tells you how many vehicles are doing the carrying. And it is the number of vehicles, the particle count, that determines how much damage is being done to your arterial walls. You can have an LDL that looks perfectly acceptable while your particle count is dangerously high. A 2020 analysis in the European Heart Journal concluded that ApoB is superior to LDL for predicting cardiovascular events, yet most executive health screens do not include it. I have had clients bring me reports costing £3,000, £4,000, £5,000 with no ApoB measurement anywhere in the document, while we are on cardiovascular risk, lipoprotein A, LPA. This is a genetically determined risk factor. You only need to test it once in your lifetime because it rarely changes. It is a major independent predictor of cardiovascular disease, and most people have never heard of it, let alone been tested for it. Marker number 2, fasting insulin. This is the one that frustrates me the most because it is so simple to test and so powerful in what it reveals. Most panels test fasting glucose and HbA1c, but insulin resistance, the precursor to type 2 diabetes and a driver of accelerated aging, begins with elevated fasting insulin, often a decade or more before glucose moves. Here is what happens. Your cells become resistant to insulin. Your pancreas compensates by producing more. The extra insulin keeps your glucose in check, so glucose looks normal, HbA1c looks normal, your GP says you are fine, but your pancreas is working 3 times harder than it should just to maintain that appearance of normality. I had a fund manager, I will tell you about him in a moment, whose fasting insulin was 16. His glucose was 5.1. His GP had never tested insulin and had told him he was metabolically healthy. He was not. He was roughly 8 years into a metabolic crisis that nobody had detected because nobody had looked. I consider optimal fasting insulin to be below 5 microunits per milliliter. The standard reference range goes up to 25. That gap between 5 and 25 is where disease develops in silence. Marker number 3, HSCRP, high sensitivity, C-reactive protein. Chronic low-grade inflammation is now recognized as one of the primary engines of age-related disease, cardiovascular disease, neurodegeneration, metabolic dysfunction, even certain cancers. The cumulative effect of years of chronic stress, poor sleep, processed food, and too little recovery. The marker for it is HSCRP, high sensitivity CRP, not standard CRP, which only rises when you have an acute infection. HSCRP detects the subtle, persistent inflammation that builds over years without symptoms. I want to see HSCRP below 0.5 milligrams per litre. The standard range considers anything below 5 as normal, so a client sitting at 3.0 gets a green light from their annual medical, while running 10 times the level of inflammation I consider safe. That gap is extraordinary. And it is where biological aging accelerates quietly in the background while you are being told everything is fine. Let me tell you about the fund manager I mentioned. This is a composite of several clients, but the details are accurate. He was 51, managed a team of 40 people, worked 12-hour days minimum, exercised 4 times a week religiously. His diet was better than most. He had a company-provided executive medical every year that cost roughly £4,000. Every year all clear, every year reassured. He came to me because a friend of his, a client of mine, told him to get a proper assessment. His words to me in the first consultation were, "I am probably wasting your time. I am the healthiest person I know." His ApoB was 1.3 grams per litre. I want it below 0.7. His fasting insulin was 16. I want it below 5. His HCRP was 3.1. I want it below 0.5. His homocysteine was elevated. And when we ran a coronary artery calcium score, a scan that takes 10 minutes and costs about £150, he had early calcification in his left anterior descending artery. He did not speak for about 10 seconds. Then he said, "How is this possible? I do everything right." And the answer is, he did do many things right, but nobody was measuring the right things. 4 years of executive medicals, roughly £16,000 in total, and not one of them had tested the markers that actually predicted his risk. We intervened, restructured his nutrition, addressed his insulin resistance through meal timing and composition, introduced a targeted supplementation protocol, optimized his exercise, more zone 2, less high intensity, addressed sleep architecture. 9 months later, his ApoB was 0.65, his fasting insulin was 4.2, his HSCRP was 0.4, the calcification had not progressed. His trajectory is now fundamentally different from where it was heading, but only because somebody finally tested the right things. So what does a proper assessment actually include? Let me show you the difference between what you are probably getting and what I run on every client who walks through my door. Your standard executive medical gives you a full blood count. Liver function, kidney function, thyroid, usually just TSH, fasting glucose, HbA1c, a basic lipid panel with total cholesterol and LDL, and a blood pressure reading. That is the fire alarm. It will tell you if something is already broken. Here is what I add to build the smoke detector. Metabolically, fasting insulin alongside glucose and HbA1c. This gives you the trajectory, not just the snapshot. It tells you where your metabolism is heading, not just where it is today. Cardiovascular, ApoB, LPA, and for anyone over 40 with risk factors, a coronary artery calcium score. Together, these give you a fundamentally more accurate picture of cardiovascular risk than cholesterol alone. Inflammatory, hsCRP and homocysteine. Homocysteine is an amino acid that, when elevated, increases cardiovascular and neurological risk. It is easily correctable with the right B vitamin protocol, yet it is almost never tested. Hormonal, not just testosterone or estrogen in isolation, but DHEAS, free testosterone, SHBG, and a proper thyroid panel, free T3, free T4, and thyroid antibodies. TSH alone misses subclinical thyroid dysfunction in a significant percentage of cases. Longevity-specific vitamin D at optimal levels. I want to see 100 to 150 nanomoles per litre, not just within range, omega-3 index, and where indicated, methylation markers and biological age assessment through epigenetic testing. None of this is exotic. Every test I just described is available in the United Kingdom today. Most cost less than a restaurant meal. The difference between the standard panel and this panel is not technology. It is not cost. It is philosophy. One asks, is there disease present? The other asks, is there dysfunction developing? And can we intercept it before it becomes disease? Now, I know many of you have GPs you trust. I'm not suggesting you abandon your doctor. I am suggesting you walk into your next appointment with better questions. Ask specifically for fasting insulin, ApoB, hsCRP, and homocysteine. If your GP asks why, tell them you are interested in prevention and optimization, not just disease screening. Most will accommodate this. Some may push back because these tests are not part of standard guidelines, and that is true. They are not. Standard guidelines are designed for population-level screening, not for someone who wants to perform at the highest level for the next 30 years. You are not being difficult. You are being proactive. You are doing what you do in every other domain of your life, demanding better data so you can make better decisions. And if your GP is unable or unwilling, a private panel through a reputable laboratory costs between £100 and £300 and can be arranged without a referral. If this has changed how you think about monitoring your health, subscribe. Every Tuesday I go deep on one aspect of executive longevity, the science, the protocols, and the clinical reality that most people never hear about. Take the free Executive Longevity Scorecard, 8 minutes, personalized report across the 6 pillars that predict long-term health and performance. No cost. The link is in the description. And this Saturday, something a little different. I am walking you through what I actually eat on a full 14-hour clinic day, not a theoretical protocol, my actual food, my actual timing, and the reasoning behind every choice, including the one meal most longevity influencers would tell you to skip. I will see you then.